Hi everyone, I'm Lee Hamley and good afternoon. I'm the Chief Medical Officer at Alfred Health, aka the other Adult Major Trauma Centre and Hospital 129. So I'm going to talk this afternoon about a Metropolitan Hospital perspective. Right. So when we have a high profile failure, there's clinical service reviews, and some of these comments are often made. There's a lack of basic care, an acceptance of poor standards, a failure of local governance. And that was nearly 5 years ago in the Mid-Staffordshire report in the NHS, and I guess we could be echoing many of the same things in Stephen's report more recently. So to a certain extent, Stephen's report is back to the future and identifying common and recurring deficiencies in care. So I suppose what we're all trying to be is highly reliable organisations and treat our patients the right way 100% of the time. And boy, is that hard. Like, we have multiple sites, 9,000 staff, 1,600 doctors, and it's a real challenge. So what I'm going to talk about this afternoon is a bit about some of the VASM data, so I won't have to explain that to you because others have already done that, and a bit about our clinical governance framework at Alfred Health to let you know that we've actually got one and what we do with it, and some of our improvement projects that we've been implementing along the way. So this is where Hospital 129 comes in, and as Ewan and I think Claudia mentioned, VASM started looking at preventability questions, and it turns out that we were a low outlier on the preventable deaths metric compared to the Victorian mean. I was asked to talk about the benefits and challenges. I'm going to try and talk a little bit about understanding why we might be in that spot. I've got my head of surgery, Bill Johnson, sitting next to me. I think if we were completely honest, we probably don't have a clue, but I'll throw the racket at it. I'm happy to talk about some of the challenges because we've still got plenty of them. So the audited deaths, this is over the 5-year period, and we had 537 in this category, and these are sort of indicative features only. They're not statistically significant, but our median age male was slightly lower than state and national hospitals. Male-female ratio and emergency admission percent was slightly higher. We had a lot of patients that had at least one operation, over 95%. And ASA status, nearly a quarter of our patients were ASA 5 or 6. And the preoperative risk of death that I think David spoke about, 3/4 had an assessment of considerable or expected. And David mentioned some of the positive, contributing factors in the audited deaths. Some of the positives at Alfred Health, this is going to get confusing with double negatives. So patients who didn't go to ICU when they should have, we're a positive outlier on that aspect. So most patients who should have gone to ICU or more patients who should have got to ICU got to ICU. Generally, we did okay on post-op complications and unplanned return to ICU. We did well on fluid balance issues, and whether that's related to the ICU, I don't know, but possibly. We did not bad on unplanned return to OR and clinically significant infection. We weren't very good at DVT prophylaxis, and we already knew that, and I'll talk a bit about what we're doing. We had 1.9% of the audited deaths had issues with DVT prophylaxis, and we were similar in a whole range of things that you can see on the slide: delay in diagnosis and consultant in theatre, etc. So we have a clinical governance framework that we've had in place for probably 9-ish years, and this is a busy slide, but it shows that we've got some governance elements around strategy, monitoring, compliance and leadership. And I'm going to talk about the ones that I've circled there. And we also have some action areas that look at things like risk management, clinical effectiveness, workforce and consumer participation, and I'm going to focus on risk management and clinical effectiveness and talk a little bit about credentialing and scope of practice. So under the strategy heading, we've had a deliberate strategy, I suppose, at Alfred Health. I guess we like having complicated patients and we've got lots of them. So we've got a large number of statewide services. We're the other major trauma centre and major adult burn centre, etc. And just while we're on the trauma theme, as you can see from this slide, we have 9,000 trauma admissions per annum, over 3,000 trauma call-outs, nearly 1,500 major traumas, and a large number of those have an injury severity score of greater than 12. So what does that mean? That means we've got a lot of very sick patients in the hospital. And going back to the previous slide, what does that mean? That means we've got pretty good 24-hour support that other hospitals don't necessarily have. And I know we're one of the few places, for example, that has 24-hour on-site consultant anaesthetists and intensivists. And when we recently talked to the intensivists about the need for them to be on site 24/7, because they have a pretty onerous roster, they decided that they didn't want to go home. They really needed to be in the hospital. The other thing we've done at a sort of strategy level is we have pretty good role delineation between our campuses, and it's pretty clear to people who should go where. So we've stopped transferring patients with acute abdomens. We nearly killed a few people moving them between campuses. So Bill, my surgical lead here, has put his foot down and said we're not doing this anymore, which is a good thing. We've also restricted things like thyroid surgery to one centre because we couldn't have enough volume at two centres. And it wasn't so much the volume, it was how do we assure ourselves that we've got really good post-operative nursing care at both centres. So we've now moved all of that to the Alfred. The other thing we believe in is not keeping people in hospital when they don't need to be. And that shaded bar is from Health Roundtable data that shows essentially case mix adjusted length of stay. And we're one of the lower ones in the data set, because the longer you stay in hospital, the more likely you are to get complications and infections and DVTs and pressure injuries and fall over. So under the element of culture and leadership, I started off, I put down, we've got strong clinical leadership. I thought, gee, that's a really easy thing to say. Then I thought, well, we do have 7 doctors on the executive, and I think that might be quite unusual. My boss, who's the CEO, says that doctors at the end of the day make a lot of pretty significant decisions, so they should be at the top table, whether it's about quality, money or other things. I thought I would try and provide a bit of evidence about a culture of improvement. There's a thing called the People Matter survey, which some of you may have had the misfortune to fill out. It's incredibly long and we have to do it annually, and it's a thing that, it's what sort of like taxes. It's your tax return, you've just got to do it if you work in the public sector. But these are the top 5 statements for Alfred Health with the highest agreement of the staff completing the survey. And number 1 was, my organisation provides high quality services to the Victorian community. And all of these statements actually talk about best practice and patient satisfaction and providing good service. And I guess it's a really indicative thing for us, that this is what our staff see as the important things to them. Oh, actually, the other thing we've done is invest a bit in leadership. So we've had some unit head programs that we run regularly. We go away for a couple of day love-in. We even got the surgeons to come, which was a different experience than the sort of psychiatrists and aged care physicians, but fun nonetheless. We introduced 360 review processes for senior medical staff about 8 years ago. Bill can tell you we nearly had a revolution because we started in general surgery and they got out the league table and I got 8.4. Why did you get 8.5? Knowing full well it could not possibly be statistically significantly different. But it's now just part of the way we work at Alfred Health, and people accept that they get their 360 review. We've also had a pretty long-standing process for staff being able to raise a concern or complaint about a member of the senior medical staff. And we probably have, this is not a bullying thing, that's a different domain, this is a clinical practice thing. And we probably have 1 or 2 a year that we deal with in that space. In terms of monitoring the scope of practice, about 5 years ago we decided we couldn't possibly know what our doctors were doing unless we had it done electronically. So we implemented a system called CGov, and we've now got a very comprehensive credentialing and scope of practice across all the senior medical staff. So for example, there might be a list of 10 or 12 things under a particular discipline that's a special scope of practice. For example, pulmonary thromboendarterectomy in cardiothoracic surgery. I think there's only one person credentialed to do that. And it's easy to look up online. We can report to our board. And we've just recently extended that to the junior medical staff. So you can tell pretty quickly who's allowed to open theatre without having a consultant on site. And we've got non-surgical procedural junior staff on that as well. Rodney talked a bit about audit. We've had a very strong program of organisational redesign at Alfred Health, and without going into a lot of detail, part of this was to move patients through the system in a safe and timely manner. And this was called TQC. And when we first started it, we talked to the clinical staff and said, what will it take to get patients out of the emergency department overnight? And everyone went, this isn't going to happen. It's not safe to move patients out of the emergency department overnight. So we introduced a hospital at night program, and there's teams, both medical and nursing teams, and we have an on-site clinical lead who is an ICU or Gen Med registrar. And it's an awful lot easier for the junior staff to actually go and ask what they may think is a silly question, but maybe an important question to someone who's there, rather than ringing someone that they have to wake up. And that's been very successful and very popular with the junior staff. I'll talk a little bit about a couple of our other projects, our medical emergency team, or MET program, and MET sustainability, and just briefly mention we also have a comprehensive morbidity and mortality program, and we require every unit in Alfred Health to do an annual audit presentation, and last year we got the final stragglers over the line, and so anyone can go along. The audits, units present their complications, their improvements, what they're worried about. And we also have regular presentations to our board from that process. So this is one of the outcomes of our timely quality care project. You can see from this slide we're consistently in the top quartile for patients moving out of the emergency department within 4 hours. Medical emergency. We are probably the MET capital of Australia. We have around 7,000 MET calls per annum. This is a very large number. You'll see that the green graph has a big up spike about 2011. Well, we had a sentinel event then, didn't we? We let someone essentially exsanguinate within the hospital, which was not a good thing. So we used to have MET when you feel like calling MET, and we made it mandatory because we'd done a point prevalence survey in response to the event, and we found that we were calling MET an abysmally low percentage of times when patients met criteria. So this provides a lot of support to our clinical staff. It's a big burden, and we've kind of got to the point of thinking, can we do this more cleverly? So last year we looked at a MET sustainability program. And what this means is we still call the MET call, but in selected units, and at the moment it's trauma, general medicine and cardiology, where they have really good senior support in daytime hours. The ICU is on standby, but they don't go unless they're specifically requested to go. And that has really, hasn't changed the outcomes, but has really improved the life of the ICU people in terms of the MET activity. We also look at whether we've got a problem by day of week, and it's pretty standard across the week. We aren't calling thousands across the weekend, which I guess is a good sign. Deaths. So this is under the area of risk management. We have our M&M process. The other thing we do is we screen all deaths daily. So the clinical governance team go to the mortuary and they have certain flags that they look at and identify patients. It might be an elective surgical death or a patient that's had multiple MET calls, and they then escalate those patients to the Director of Medical Services, and who will make a decision whether we refer it back to the unit for further consideration at M&M, or it might go to our Clinical Outcome Review Committee, which looks at all our serious adverse events and is able to identify emerging risks, and that way we can get things on our risk register and do something about them. And how do we let the clinical community know what we find? We provide feedback via grand rounds, cases from clinical review, and we've had all sorts of things. We've talked about appendicitis, VTE, patient identification, and next week we're talking about nasogastric tubes and failure to act on significant abnormal results. Nasogastric tubes will feature in a minute because we've managed to find some issues with them. So maybe some of those things we're doing could be why we're Hospital 129 a low outlier. I don't know. We've certainly got our challenges. We know we need to do things better in VTE prophylaxis. We have problems with pressure injuries, nasogastric tubes, and our hospital-acquired complications, which is from the coded data, we're probably a high bad outlier. So VTE, what are we doing there? This was identified not only by VASM but also in our Health Roundtable data. And we do have an at-risk patient population, but we decided we needed to put some more energy into trying to improve our VTE prophylaxis. So we put on a VTE pharmacist last year whose pager number is something clot, so people can remember how to call them. We did our second internal snapshot of how we were adhering to our guidelines in 2017, and we looked at 164 surgical patients out of 217. We excluded ICU and there were some patients not able to be assessed. Overall, the rate of appropriate VTE prophylaxis was 74% and a bit better in the high risk group, not very good in the low risk group. And so we've now got an organisational action plan around that. One of the key things is actually to improve mechanical prophylaxis for high-risk patients. And it's not that we don't have it available, it's just that we don't necessarily get it there in a timely way, or it isn't on, or all of the above. And we also need to look at over-prescribing prophylaxis in low-risk patients. Nasogastric tubes. We had a cluster of these late 2016-17, and some of the complications have been very significant, and I think there have been some, at least a couple of deaths attributed to nasogastric tube misdemeanour. Both fine and wide bore tubes, although fine bore tubes are the majority. We estimate we do about 1,800 per annum. We've had 13 reported serious incidents since 2010, and although that's a small number, we suspect it's really underreported. We've tried a whole bunch of things. Probably the most significant was saying you can't reinsert a fine bore overnight, because A, you don't really need to, and B, you probably can't get the X-ray to check that it's in the right spot. None of that's really made any difference. So for 2018, we're going to bite the bullet and credential staff to do fine-bore nasogastric insertion. For those of you who don't know about nasogastrics, these are often put in by nurses, and they have a few goes, and when they can't get it in, they'll go to the junior doctor and say, can you put in this nasogastric tube? And they may not have put one in ever, or not recently. So we're going to go to credentialed staff. We're removing fine-bore tubes from wards where they're not used often, and if someone in one of those wards needs a fine-bore nasogastric tube, then someone from a high-use ward will come and do it. And we haven't got all that in yet, but that's our plan for 2018, so watch this space. But we have a very lovely collection of x-rays with nasogastrics in all sorts of places where they shouldn't be. So we know that patients frequently suffer avoidable harm while receiving care, and I guess we're all trying to reduce this. And this is a quote from Stephen's report: no one should accept avoidable harm as an inevitable and ineradicable feature of healthcare. And I guess at Alfred Health we're trying hard to live up to that sentiment. Thank you.